Welcome back to Therapeutics. In this block, we're going to review the therapeutic options for patients with heart failure. Our objectives include looking at the latest nationally accepted goals and clarification of the management of heart failure. These were from the latter part of 2022, as well as some updated key studies that have looked at newer modalities in the management of heart failure. We'll also differentiate the other classes, most of which we've talked about already in hypertension. And we'll spend a little time also talking about the management of acute decompensated heart failure, where we might use for short-term vasopressors, inotropes in the ICU setting. So let's go on to heart failure. Before we start to talk about the therapeutic management of patients with heart failure, we have to appreciate some of the pathophysiology in heart failure to appreciate which modalities, which drugs in our toolbox, which other factors are going to offer the most benefit for the individual in front of us. So to be able to do that, we have to have a pretty reasonable conceptual understanding of heart failure. When we think of patients with heart failure, primarily we're looking at patients who have some decrease in their cardiac output. And for us to remember, cardiac output is a function of heart rate and stroke volume. So to the extent that we can augment or affect heart rate or affect stroke volume with the therapeutic options we have, by default, hopefully we can have some positive impact on cardiac output as well. Heart rate, for the most part, is controlled by the autonomic nervous system, whereas stroke volume is determined by three primary factors: myocardial contractility, cardiac preload, and cardiac afterload. As we're trying to quantify that, we basically look at cardiac output in mils per minute, or cardiac index, which is cardiac output as a function of body surface area, is equal to stroke volume and heart rate. And so here's a simple calculation of cardiac output where someone's stroke volume was 70 to 80 mils per beat, and they had 70 beats per minute. The regulation of arterial pressure is going to impact some of those parameters of stroke volume, particularly as it relates to preload and afterload. And so the control systems that we're going to look and augment include the autonomic nervous system, the renin-angiotensin system, and to some degree, kidney function as well. But most of what we're going to focus on drug-wise, at least as it relates to arterial pressure, are going to be the autonomic nervous system and the renin-angiotensin system. As we look at heart failure pathophysiology, important for us to look at the Frank-Starling curve, which I am assuming, either have or will cover in Clin Med. But for the most part, as we increase fiber length, we improve the volume with each beat, the stroke volume, until the point where we actually may do some overstretching. At that point, it actually becomes counterproductive. Once we get to the top of this curve and start to actually go down, we find that for individuals who have some problem with contractility, by overstretching the ventricle, we actually have less contact with the actin-myosin layers in the heart because they're overstretched, and we actually lose contractility, and therefore we lose some stroke volume. So sometimes our goal is to reduce the fiber length by reducing preload so that we can have the most benefit in the stroke volume we have, and also to improve stroke volume by not having to press against a high pressure system, by reducing arterial pressures, by reducing afterload. And so our goals here to get folks to a point where their stroke volume is maximized, we're going to do that by affecting preload so you don't overstretch the fiber length, and affecting afterload by having the heart not have to work against a high pressure system. There are a number of variants that occur as patients develop heart failure, and we're realizing more and more that not just dealing with the renin-angiotensin system directly alone is going to solve this problem. Not just decreasing heart rate or affecting heart rate is going to do that. Not just increasing contractility is going to do that. But there are a lot of other mechanisms that have come to bear to be understood in the last 30 years or so about the pathophysiology in heart failure. And that's led to some of the new therapeutic options we have in the management of heart failure. There are a number of neurohormonal activation steps that happen in a patient who has reduced cardiac output. And so, with long-standing hypertension and with other factors that are contributors to patients having heart failure, the body may respond in a way that it thinks it's improving perfusion by improving cardiac output, maybe in the short term, or thinks it's doing that, but they're actually counterproductive. So in these cases, we have an overexpression of norepinephrine. We have an overexpression of the renin-angiotensin system. We have problems with aldosterone secretion and extract salt and water. All of that, which actually increase preload and afterload in a way that's not helpful, or contribute to inflammatory states that ultimately lead to poorer cardiac outputs and poorer overall outcomes. And so when we look at some of the therapeutics we're going to talk about, we're going to look at tamping down some of these compensatory mechanisms that are associated with actually worse outcomes in patients with heart failure by intervening with the renin-angiotensin system, intervening with norepinephrine stimulation, also dealing with aldosterone, and also dealing with inflammation and other inflammatory states that happen in conjunction with heart failure. As we look at heart failure stages in practice, we will see that the American Heart Association, American College of Cardiology has had for years these stages A, B, C, and D. And then there is a functional class system, the New York Heart Association functional classes, which indicate whether someone is asymptomatic, functional class 1, slight limitations, marked limitations, or symptoms at rest, and that's 2, 3, and 4. Historically, we've used the New York Heart Association functional classes as much or even more than the classes A, B, and C. And but we're seeing that some of the new guidelines are more directed at the AHA, ACC's classes as well. But we still find that the New York Heart Association functional class system is helpful for us to get a sort of snapshot of how a patient is doing clinically. So let's walk through some of the treatments for heart failure. These first two slides are some of the more common agents we use currently in the management of heart failure. They each have their niche or their sequencing associated with them. The order of these slides isn't necessarily the ordering of the sequence of how they're rolled out in heart failure management. But let's go through these, many of which we've already talked about, a few of them we haven't yet. So first, let's talk about aldosterone antagonists. And the big drug here is spironolactone. Spironolactone has been around for a long time. We've used it in ascites. We talk about that in the GI block. We have historically sometimes considered drugs like spironolactone for other purposes as well, sometimes used for severe acne, for example, in patients refractory to other therapies because it has an effect on testosterone as an antagonist. But for the most part, spironolactone is actually, in heart failure, a great drug if patients can tolerate it. Associated with significant improvements in morbidity and mortality. The problem with spironolactone is we have many patients who cannot tolerate it with an ACE or an ARB on board because their potassium levels get too high or their renal function has fallen off. But by intervening with aldosterone, interrupting aldosterone as an antagonist, we reduce preload and we reduce afterload. And we actually have some pretty good morbidity mortality data with spironolactone. So spironolactone has become one of the earlier drugs we like to add on to regimens for patients with heart failure. Very commonly, almost universally, we're going to add an ACE or an ARB on board. And in this day and age, the newest guidelines on the next page, we talk about the neprilysin inhibitor added as well to an ARB. And that's become really first-line therapy for most patients with heart failure. ACEs and ARBs do a great job at reducing preload and afterload. And look back on how we covered ACEs and ARBs in hypertension block and how they fit there. It should make sense that they make a lot of sense in patients to reduce salt and water accumulation and a little bit of vasodilation to improve afterload in patients with heart failure. The big change for us in 2022 is the very fast from not using a heart failure at all to a first-line therapy in heart failure are the SGLT2 inhibitors. These drugs first really developed for glycemic control in patients who have type 2 diabetes have quickly become a first-line agent in most patients with heart failure. They reduce preload and afterload. They are also associated with some other nice factors. They downregulate norepinephrine. They reduce inflammation. They improve intercellular ATP. They do a lot of things to do all the right things at long-term improvements for patients with heart failure. And so it is becoming very much a first-line regimen to consider these in adding them in patients with heart failure. The dilemma is, of course, that they're expensive. And so the speed bumps that you'll find with this agent, an SGLT2 inhibitor, what you'll find with an neprilysin inhibitor added to an ARB is that the speed bump you'll likely have is cost. And will it be require a prior auth if the patient has insurance? Is there another way to get it provided for the patient? Those are going to be speed bumps you're likely going to have. That said, by the AHA really recommending that these agents are frontline now in heart failure should hopefully make it easier for insurers to cover these much more routinely. So hopefully that will happen. Beta blockers also are a big deal in heart failure. 40 years ago, we would think a patient with heart failure, it would be contraindicated to use a beta blocker because you would think, gee, I've got somebody with poor cardiac output. Why am I slowing down their heart rate? Isn't that bad for cardiac output? Because you think of stroke volume and times heart rate equals cardiac output. But what these three beta blockers, very specific, there's only three that are studied in heart failure. That's carvedilol, both the short and long acting, only the long-acting form of metoprolol, not the short-acting form, or bisoprolol. These are the agents that have been studied and are considered those agents that are approved for heart failure use. And we start them at relatively lower doses, but we try to titrate folks up to their highest tolerated dose because they will, like we see with the SGLT2s, downregulate some of the norepinephrine overdrive that serves to be counterproductive long-term in patients with heart failure. The next set of, the second set of slides here are also pretty commonly used agents. Let's put these in context. The neprilysin inhibitor is not available as its own agent, but only in combination with valsartan currently. I would expect that there are going to be other ones and other combinations available at some point in the future. But the addition of a neprilysin inhibitor to an ARB additionally reduces preload and afterload compared to an ARB, for example, alone. And so this has more benefit than an ARB alone. If a patient couldn't tolerate the neprilysin inhibitor with the ARB, then using an ARB alone is reasonable, but you really want to try to use the combination if that's at all possible. Finally, the main other steps here are if a patient has fluid overload, which is very common, you're going to look at your physical assessment for the patient, check their weights every day. You're going to try to see if they're fluid overloaded. The answer is primarily a loop diuretic. You want to think of the good and the bad news here. The loop diuretics are very good at getting the fluid off. You have to watch potassium wasting, which usually isn't a problem if they have a ARB or an ACE on board, or if they have spironolactone on board, or both. But you do have to worry about overshooting the diuresis with them and throwing them into acute kidney injury because you have got them dehydrated and then poor perfusion to the kidney. And so you have to be careful about that. But loop diuretics are the way to go in heart failure when you need to get fluid off. It's furosemide. It may also be bumetanide or torsemide, but usually it's furosemide, either IV or oral. We'll talk about that in a bit. Occasionally, you'll have patients, or maybe if it's an admitted patient in the hospital, patients for whom your furosemide or your loop diuretics aren't quite doing the trick for you. You could either go with a continuous infusion IV of a loop diuretic, or the other thing we sometimes do, and it works, is give a chaser of a thiazide diuretic, for which the thiazide most commonly used for that purpose is metallazone, not the prototype drug here, but that's usually given 30 minutes before the furosemide. And for patients who haven't gotten a lot of fluid off or are refractory to their furosemide, sometimes that thiazide push, in addition to the furosemide, just does the trick to get them to pee and get rid of some more fluid and help their cardiac output a bit. The last two drugs on this slide are the vasodilators, and these are primarily used for patients who may not respond to renin, angiotensin interventions as well. And primarily that's probably genetic, and it usually is an individual who is self-identified as Black. And for these individuals, we still start them on an ACE or an ARB with an aprelozin inhibitor and go through the strategy. But if you have maximized the goal-directed therapy options that best you can, and you still don't have the kind of control you want, and you still have symptoms, it is pretty common in this cohort, and others probably maybe as well, to try hydralazine with a nitroglycerin to reduce preload. And so that's a common additional intervention we'll see happen. The next two slides are agents which have a limited, if any, role in heart failure. Some of them do, and we'll talk about each of them. They have their niche or their place. Sometimes, though, they're more problematic than beneficial. And so let's talk a bit about those. First, calcium channel blockers. We never use calcium channel blockers in patients who have a reduced ejection fraction, particularly because they will reduce contractility. So we're really careful about how we use calcium channel blockers at all. There is a limited role in heart failure patients for considering in patients who have a stiff ventricle, which affects stroke volume. It's a limited number of patients who have diastolic dysfunction. In these individuals, there's sometimes maybe a benefit for considering a calcium channel blocker to increase stroke volume by allowing more relaxation between beats to allow for a larger stroke volume. But I'd be quite honest that I think I would leave that decision about a calcium channel blocker in a heart failure patient to the cardiologists and not so much you. But if you had somebody who's on a calcium channel blocker and they're going into heart failure, then that's a consideration you want to make. Okay, so be thinking about that. Cardiac glycosides, really digoxin. We'll talk about digoxin. It increases contractility. The benefits for digoxin, there is really, among everything else we talked about on the first two slides, probably has some degree of mortality benefit. Digoxin has no mortality benefit. It won't extend your life, but it reduces the potential of having to be symptomatic enough to go in the hospital for a subset of patients. So digoxin is one of those therapies that if you have completed and maximized your goal-directed therapy with an ACE or an ARB with an aprilocin inhibitor, and you've trialed or considered spironolactone, you've got them on an SGLT2, you've, all at max doses, diuretics when you need them. You've kind of walked through that plan with them, uh, and they've maximized it, and they're still symptomatic. Digoxin may make sense. That's a fairly limited cohort. So we don't see digoxin used very often in heart failure. Sometimes we do. More often we use it for slowing conduction to the AV node in a patient who has AFib or AFlutter. So that's where you're going to see digoxin. Where you might see that, though, is you've got somebody with AFib or AFlutter for whom you don't want to give them diltiazem because they have a reduced ejection fraction. You've kind of maximized what they can currently tolerate with a beta blocker like metoprolol. And so what are you now doing? You're considering using digoxin for the patient with reduced ejection fraction and AFib to both control their ventricular rate and maybe help a bit with their AFib, with their heart failure symptoms as well. For CoQ10, it may cause some benefit and increased contractility, but truth be told, there's really no data at all that really support their use. They're no longer recommended in the guidelines, not that they ever really were. But early studies, particularly early studies in Asia and Japan, had looked at some beneficial data for CoQ10. That data is lacking. And so we don't really consider CoQ10 a treatment option for heart failure. For using the inotropes, either a catecholamine like dopamine or or dobutamine, or a non-catecholamine like amrinone or inamrinone, so it doesn't get confused with other drugs. These are really limited to acute decompensated heart failure in the ICU for a day or 2 days. These are not long-term therapies. They increase contractility. We're only going to use them when cardiac index is really low on a patient, and you're probably going to have the intensivists with the cardiologist right there to guide you on where they fit and where they don't fit, but not very common. We'll talk about them in acute decompensated heart failure. Finally, the last two are treatments that are rarely used. They're fairly newer modalities. They're kind of far down on the line when you've exhausted everything else and you still got someone symptomatic. One is ivermectin, which reduces heart rate. And if you've maximized their beta blocker and they still have a heart rate above 70 and they can't tolerate any more beta blocker and you might see ivermectin used, but I honestly rarely see it used. We'll talk about it in a minute. And finally, the soluble guanylate cyclase stimulators, there's really only one new to the market, reducing preload and afterload. Again, is an agent that is sort of new in the mix, is again for, after you've done the major things. You're not going to see that very often, but you may see it added on in patients who have really done everything else. So let's spend a couple of minutes going through the drugs that we have not talked about in hypertension that are on these slides. First, let's start with the SGLT2 inhibitors, which we cover also in the endocrine block for diabetes. These sodium glucose cotransporter 2 inhibitors are effective at increasing the excretion of both glucose and sodium in the urine. So you've got a little extra fluid coming off there. That's a good thing in heart failure. They decrease interglomerular pressure, which may offer some renal benefit. But the big issues in heart failure are that they reduce preload, they reduce afterload, they downregulate the sympathetic activity like we see with beta blockers. They also have some anti-inflammatory action by affecting epicardial fat and oxidative stress to some degree. They also affect intracellular calcium function and ATP intracellularly, which improves contractility as well. So we're finding there are lots of mechanisms for these SGLT2s, and that's kind of why, at least in theory, they make a lot of sense. What really renders the SGLT2 inhibitors, at least as a good approach in improving cardiovascular outcomes, particularly in individuals with heart failure, is depicted in this slide. And if you go about 3/4 of the way down the slide and look to the steps of ultimately all of these mechanisms reduce epicardial fat, reduce oxidative stress, inflammation, improve contractility, and improve ATP production in the cell, all improving cardiac output. This is the first of a number of slides where I have a little key symbol. And it's not so much that I want you to pay that much more attention to these slides than others, but I think these represent some really key things in our thinking and practice, or where we see sort of major changes or major emphasis in practice going. So the SGLT2s are really new within the last year to our treatment of patients with heart failure, and these guidelines are really putting them front and center for therapeutics. Well, it's more than just theory now. It's really this study that's about a year old now uh, that looked at these agents in heart failure patients who did not have diabetes. They looked at both patients with and without type 2 diabetes and heart failure, and they looked at outcomes. What they found is that they saw significant improvements in cardiovascular death as well as hospitalizations uh, in patients who received an SGLT2 compared to patients who did not. If you look at this 2-year trajectory of patients who had randomized in blue to the SGLT2 versus red placebo, you can see really some significant differences in the number of patients who have had events or not. So real improvements in outcomes. And in the endocrine block, we talk about the SGLT2 inhibitors, what to kind of think about. And they also are a mainline therapy for patients who have type 2 diabetes. And for diabetes, their efficacy is pretty good, not as good as other therapies at lowering glycemic index and affecting hemoglobin A1C. But the good news is that these drugs don't cause hypoglycemia. They cause a little bit of a weight loss for patients, which is always good for cardiovascular health, and that's more than fluid loss. They have some benefit for both atherosclerotic disease as well as heart failure. Unfortunately, they're expensive. Good news is that they're oral. They also have some benefit in renal function and progression of kidney disease, particularly in patients with some degree of heart failure. So lots of things that are evolving with this class of drugs. The prilosec inhibitors, really there's only one in the market, have an advantage too. And they work at an enzyme responsible for atrial and brain natriuretic peptide. And here, these drugs work to some degree, reduce blood volume and blood pressure by this inhibition. But it's only available as a combination with a angiotensin receptor blocker, valsartan, as a combo drug, and it is a first-line therapy in the 2022 guidelines for heart failure. This graphic probably is a simplistic cartoon that pretty much looks at what naproxen does and what angiotensin II blockade does. And together, they are going to be seen as helpful in patients with heart failure. The IF current inhibitors, ivabrandine is really the only one. It reduces spontaneous pacemaker activity in the sinus node, so you see a decreased heart rate associated with improvement in heart failure patients. But it's really only after you've maximized everything else before you'd go here. And I'll tell you quite honestly, I don't see many patients. This drug's been around for 3 or 4 years, 5 years, and I don't see a lot of real benefit. The 2017 guidelines had a place for them, and pretty much the 2022 guidelines say the same thing. So there's really not a lot of difference there. Here's a graphic of how it works. Basically, the sodium, the fast channel sodium affecting depolarization, you see a bit of a delay in that inclusion or slowdown of the inclusion of sodium potassium on the initial depolarization, for which you see a longer heart rate interval, and that's correlated with some improvements in cardiac output in patients with heart failure, but not a lot. And even though it has a role, it's most maximal beta blockers probably do the trick for 98+% of patients. So ivabrandine, again, not a commonly used agent. Another new category in the block are the soluble guanylate cyclase stimulators. There are 2 of them that are on the market. Their mechanisms are to work to enhance nitrous oxide mediated pulmonary artery vasodilation. And while these drugs are similar, one's used in heart failure, one's used in pulmonary hypertension. Both of them not very commonly used, not a first-line agent, fairly new to the market. So we're always a little concerned when we see a sort of a new category of drugs where we don't necessarily know the safety profile. The SGLT2 data is really strong. So, we've had some data with that over the last 5 years or so. So we have a lot of patients on that. We understand what to expect. These soluble guanylate cyclase stimulators, we've had less experience with. We know they're potentially teratogenic. They can cause hypertension, anemia, headache, pedal edema, which makes it hard when you've got a patient who has pedal edema and they also have heart failure to figure out what's what. But you may see them. There's a place for these drugs, but they're pretty far along. Usually by that time, they're probably seen by a cardiologist. Finally, the role of the inotropes. The first inotrope, digoxin, which we talked about also in the arrhythmia section, they inhibit the sodium potassium ATPase pump that ultimately leads to both more calcium in the cells and also slows conduction through the AV node. It's the more calciums in the cells and increasing contractility that DIG is used in heart failure, but no mortality benefit, although there is a morbidity benefit. We more likely use it for paroxysmal supraventricular tachyarrhythmias when you can't use metoprolol or diazepam, or you might use it in heart failure, but again, a more limited role. You're always worried about electrolytes, renal function, VFib risk, DIG toxicity can be disastrous. So it's not a great drug to use. Clinicians really don't like to use DIG unless you absolutely have to. Considerations are that you worry about renal function with these folks who then end up in DIG toxicity. It's a narrow therapeutic index drug. You're chasing electrolytes with them. You're really careful about them. So again, digoxin not commonly used. The rest of the inotropes are given intravenously only and are used only very short term in ICU in a pretty significantly acutely decompensated patient. The main ones are milrinone or amrinone, also known as inamrinone, to not confuse it with other sound-alike drug names. and they work as positive inotropes. For the most part, we don't see them used that much. They're only used in the ICU. If, however, your practice is critical care or cardiac care, you may see them used for a window of time, not only in patients with acute decompensated heart failure, but sometimes we see individuals who have a cardiogenic shock post cardiac surgery where they might use them really short term in a cardiac ICU setting post surgically, but pretty limited in their role there and a pretty specific role or goal. These drugs pretty well tolerated for the most part, but you want to be careful about, they have their own specificity of being used.